Dr. Dilip Kumar Joyshwal, the Honorable Director Sir, who has a very clear vision for developing something, and not only that, he can implement it as it is required. So that is his big quality, what I think, and that is the reason why it was more than 30 years back. It was started with a Matagusti Medical College with 60 students undergraduate, and now you can see what is the state of this institute. It is not only medical college but university having some other degree courses also. And then of course we have great opportunity to have Dr. Srivastava. He was ex head of the department, and after retirement he joined one medical college and he is working there. We have the opportunity to learn from him about the spines, and he will discuss it in detail. And he was also president of the Bombay Maharashtra Spine Society, is it? Maharashtra Spine Society, and he is very eminent speaker also. So that is our benefit. And also I like to welcome all our faculties of the Department of Orthopaedics. I am not mentioning separately, and also my beloved student. And the radiology department is welcome also to join this program. Professor Reja is here, head of the Department of Radiology, and also Professor Dr. Jadhav. He will be also speaking here. And our faculty, Dr. Srivastava and also Professor Papa, they are also participating in the lectures. So without wasting any more time, let me invite our inaugurator, Professor Joyshwal, Dr. Joyshwal, to say something. 26.
My beloved Department of Orthopaedics, Assistant Professor in Department of Professor K.J.Somaiya is my father. We are very blessed. My talk is a very basic talk. I am going to talk about general schematic, I won't say a schematic, L1, L5, C1, C2, and lower cervical, which is C3, C7, thoracic, lumbar, and sacropoccygeal. Now, these are the 9 fused vertebrae. If you see in total, the sacral 5 vertebrae are fused together and the coccygeal 4. This is the basic vertebral structure. You see the cervical spine here. Okay. Now you compare the body, the cervical vertebral body, the thoracic vertebral body, and the lumbar vertebral body. You compare the spinous process of all the 3 vertebrae. You check for the facet which is there for the ribs in the thoracic vertebra. Check for the superior articular process, the inferior articular process in the lumbar and the thoracic vertebra. So these are the basic differentiating factors in all these 3 vertebrae. Now this is a vertebra proper. Now if you have to look into a vertebra and see how it looks, this is a basic anatomy first year. Anterior part, that is the vertebral body, the vertebral foramen. This is the pedicle, the transverse process. This is the superior articular process, as we are seeing the supero-inferior view from the superior side. This is the superior articular process. Down will be the inferior articular process. This is the lamina and this is the spinous process. Now, this is important. This is something which we mug up, but we don't know. So when you are doing surgery, it's very important to understand how much amount of decompression is needed. Okay. So if you see, This is our friend. That is the zygoepiphyseal joint, the facet joint. Many a times when we are decompressing, we go rampant and out of bravado, we go ahead and even sacrifice this, which actually leads to instability. When you have to do a little amount of decompression, this should be your anatomical landmark. I don't have to cross this. Okay? So facet joint is important. Also, the superior articular process, the inferior articular process, this one. And this is the part. So if for the PGTs, if you are remembering, we had the Scottish dog sign. What is Scottish dog sign and where it is present? Radio PGTs can also say that. It's a radiological marker. Pars interarticularis is fracture. Okay? So that is why and that is how you get that. Yeah. Now this is the vertebral structure. This is a lateral view which we are seeing. So this is the intervertebral foramen. Okay? This is the slight notch or the low notch. This is the deep notch. Why is this important? Because through the intervertebral foramen comes out the spinal nerve roots. Okay? So all the talk which we had yesterday, exiting nerve, there is a axilla, there is a PIVD, there is a disc. This is where it comes out from. And if it's a far lateral recess PIVD, this is what is going to impinge. Okay? So this is why it's important. Vertebral arches, yeah, this is very important because it is going to actually help you when you are either going from the anterior approach or the posterior approach. So if you are going from the posterior approach, these are the things which you are going to tackle first. That is the posterior arch comprising of posterior 2/3 of the pedicle, the lamina and the spinous process. The anterior arch composed of anterior vertebral body and the anterior 1/3 of the pedicles. Yeah, this is important. So in the previous years, we had something known as the physicians, even the Egyptians, used to use called as the plumb line. So the plumb line used to actually pass like this. So what all the anatomical landmarks it is passing? It's passing the auricle of the ear, the odontoid process, body of C7, anterior thoracic spine, the first T1, it cuts the T12, posterior to the L3, that is the L3 vertebral body, and the midpoint of the femoral head, bilateral femoral head. Yeah. Now this is for the radiology department because this is what we don't prescribe properly. We should understand the planes. Okay, we should understand the planes very well. This is a normal X-ray. I won't say a normal X-ray. This is an X-ray which is normal for a patient having scoliosis. Okay, this is a normal scoliotic X-ray which is a coronal or a frontal plane. This is the sagittal view, the sagittal plane, the medial plane, and this is a CT scan where we are actually seeing the axial plane and the transverse plane. For every clinician, especially orthopedic surgeons who are the protectors of movement, the movement of spine, this is flexion, this is extension, this is left and right side bending, and this is the left and right rotation. Yeah, this is a very important slide. We should understand what is motion segment. Motion segment is the functional unit of spine. It is comprised of the two adjacent vertebra, the intervertebral disc. This is the interconnecting spinous ligaments and the two facet joints with the capsule around it. This is the spinal nerve tomography. 31 pairs of spinal nerve. We have 7 cervical vertebra, but we have 8 cervical spinal nerves, 12 thoracic vertebra and 12 cervical thoracic nerves, 5 lumbar vertebra, 5 lumbar nerves, 5 sacral vertebra, 5 sacral nerves, 4 coccygeal vertebrae, but they are fused, only 1 coccygeal nerve. Spinal nerve, this is a schematic diagram which actually tells us that how that spinal nerve root or the peripheral nerve, which we call proper, comes out. So this is which vertebra? PGTs, ये कौन सा vertebra है? ये तो मालूम होना चाहिए. ये क्या है? What is passing here? हाँ, तो vertebral artery कहाँ से जा रहा है? Cervical spine. So this is a cervical spine. Okay. This is our spinal cord. This is epidural space, the dura mater, and the arachnoid layer, the subarachnoid space. This is the dorsal root ganglion physiology. Okay. And this is the ventral root. This is the dorsal root. यहाँ पे dorsal root ganglion है, and then this forms the peripheral nerve. Pedicle anatomy. Everybody is behind passing pedicle screws, but you should understand the structure of the pedicle at each vertebra. May it be a thoracic spine, that is T3, thoracic spine 8, that is T8, and the lumbar vertebra. The diameter, the length, the way it's placed is different. Okay, so how you pass your pedicle screw is going to be different in all different vertebrae. Okay, this is your central line. This is your direction of pedicle in the T3 thoracic spine, T8 and L4. Yeah, this is important for us. In lumbar spine, we have 3 ways in how we pass a pedicle screw. Okay, so the one which I call as the bisector technique, wherein the intersection of, what is this? ये कौन सा लाइन है? इंदर सैंतन, ये हमको राउंड पे बताया गया था. कौन सा लाइन है ये?
Sir, the vertical line is through the superior facet.
Right.
And sir, mid-transverse, vertical line is through mid-transverse.
Very good. So this is the bisector principle by which we pass the pedicle screw in the lumbar vertebra. And same thing, you are following in thoracic vertebra. One thing which you need to understand is the curvature in the thoracic spine, okay, and the curvature in the lumbar spine. ये कौन सा curvature है? आदित्य, what is this? ये lordosis है, kyphotic ये है, and this is lordosis. Very important. We are going back to the old age. Okay, हम लोग जो उबड़ू बोलते हैं यहाँ पे, वैसे बैठते थे, वापस वही हो रहे हैं. ये नहीं होना है, ठीक है? हम लोग को ये बनना है. A kyphotic spine at 12 weeks fetus. Look how happy he is. Good boy. ठीक है? Thank you so much. I call.
Degenerative disease of the spine include degenerative disc disease, in-plate changes, spondylosis.
Professor Dr. S.K. Srivastava to kindly come and deliver his talk.
Now I'll be talking on the craniovertebral pathology, its understanding and effective management. It is important to realize that there are 3 important factors working in this specific region. It has a unique anatomy. You know, the C1 body is not there. And this is an OC complex which works in unison. There is a good coordination between the condyles of the occiput, the C1 ring and the C2 vertebra. And we have a complex biomechanical factors. I would actually encourage the radiology people to have a anthropometric analysis, and you can have published paper on these guidelines. There are radiological indicators. Now, as we know, there are indicators for pelvic incident. Similarly, you also have in the occipital area. And you can actually publish an Indian population. This is extremely important. In fact, we have done a lot already. The specific pathology associated factors. So different pathology, they affect the column differently. So cognizance of all these factors in a patient makes a successful foundation for long-lasting, fruitful results. Now, OC region is the top story of the spinal column. It has unique anatomy. They are vital regions with vital centers. This is the junctional area. So you have a very heavy head, the skull having the brain, and then suddenly it goes in different, column alignment, and there is a very good biomechanical SAB. So that actually holds everything very nicely, and moreover it has a very hypermobile area. The ligaments are prone to get affected, and there is a risk of instability. Now if you see, it is a Y-shaped beam. The C1 works as a small bushing between the large skull and C2, and there are vital structures as we discussed, the brain, spinal cord and vertebral artery. And the ligaments are very important, and they are the main stabilizing structure. So here the mobility is at the cost of stability. The congenital anomaly, traumatic and destructive lesion, it causes instability in this area. And since it is only ligamentous, much part is because contributed by the ligaments, the bony osseous continuity is poor. So whenever we wish to fuse this area, we have to take extra effort to have a stable onlay graft in this area. The ligaments are main stabilizing structures in this zone. As we discussed, it has a complex biomechanical factors and alignment in this area. It is quite unique. So different etiologies can affect this area. With the plain X-ray also, you can identify many of it. Congenital anomaly, there may be bony destruction in infective pathology. Neural affection is usually a case which you are going to get, and you must study what is the over alignment of the column. So the overall alignment of the column is going to give a picture of the biomechanical axis of the whole spinal column in this patient. There are various radiological parameters, and I think you might be knowing what is ADI, that is adult in interval. In adult, it should be less than 3 mm. In children, it is acceptable less than 4. So it should not be more than 4 because there is a hypermobility in that age group. And the space available for cord, if it is less than 14 mm, most of the time these patients are going to be symptomatic. So there is still rules of third. So in anterior 1/3 you have odontoid that is dense. In the center part, which is there in the center dense, and then you have arch, and also posteriorly there is available space. And in the coronal view you have this diasteroid line and digastric line, which can tell you the axial settling in that case. Okay, so there are 3 important radiological parameters: the clivus canal angle, which is commonly used, cervicomedullary angle, and cervical lordosis with distal sagittal vertical axis of the spinal column. The ignorance about normal clinical radiological parameters and facts is important. If we don't pay attention, there are poor clinical outcomes. Now I'm going to show few cases of why it has failed. You must analyze so that you don't repeat it. Now in this case, this patient has been operated. But see the distance, ADI is quite significant. So these patients, they have poor neurological recovery. This should not be accepted. There is a significantly reduced clivus canal angle. There is an increase atlanto density interval. There is a reduced retrodental space. Radiological features of neural compression are there, and that's why there was a poor neurological recovery, or there may be neurological deterioration. The implant has backed out. This is because of the poor fusion technique. So if you don't pay attention, this is going to happen, and there will be instability.
So that is how we label it. So this, what is it looks this? 5, 4, 3, 2. So A4, involvement of the superior and inferior end plate with the posterior displacement of the fragment. And what has happened here? There is a distraction. So definitely there is involvement of the PLC. PLC means posterior ligament complex. So these type of fractures there will be definite neurological involvement. So on clinical science, you can, so A4, B3, and if it is total paralysis, N4. So that is how we label the spine fractures. If the lower vertebra is involved, this is A2, N2. Okay? Okay. Thank you.
Dr. Yadav sir for his talk. We thank Dr. Yadav sir for his talk, and I'm extremely sorry for that miscommunication. Before we start, yes, Dr. Reza sir, APT.
To invite questions from the house so that the matters are more clear. So, if it is there, the Dr. Jadov is not there, but still our head of the department radiology is there, so he also can answer. Any question? Oh, that is the separate topic. That is basically on neurology, and this is the spinal. And okay, so it will not be related. It will not be ending.
I stressed on this that you can't get. That's why I have added a little bit of even the clinical some of the science and which you should be able to pick up. So I am going to talk on cervical myelopathy. What is it and how to at the junction where there is a T1. T1 starts from there may be muscle ligaments and vertebrae and affection of these neurospinal radiculopathy. So you have to have a clinical picture so of that specific nerve and palsy. Myelopathy you will have the presentation, but you can root of that level in the body. Okay. Multiple sclerosis is the very common example. Notice the cord expansion. If you see the gray thing, it is dilated. So there is a expansion of the cord. Now this side, right side, you see compressive cervical myelopathy. Because it is a degenerative cervical spine. Notice the external cord compression. So this is the major difference. Now as an orthopedic surgeon and spine surgeon, we basically deal with the compressive myelopathy. The neurologists, they deal with the non-compressive myelopathy. So compressive myelopathy, it may be congenital or acquired. Congenital usually because of the congenital AAD. Acquired one is the degenerative, traumatic, infective, inflammatory, and neoplastic. But the commonest one which you are going to get in your exam is infective and degenerative. So we say spondylotic myelopathy. It is because of the degeneration. So what is this spondylotic cervical myelopathy? Spondylotic cervical myelopathy is defined as spinal cord dysfunction secondary to extensive compression of the cord or its vascular supply or both. They may be coexistent. Okay? Now this case which I have shown, it is a case of OPLL, that is ossified posterior longitudinal ligament. And see the amount of compression this cord has, and this patient presented with the myelopathy. Now pathogenesis of degenerative cervical myelopathy, there are degenerative changes in the cervical spine. The disc space and facet joint shows different degenerative changes. In disc space you will find osteophyte, there may be arthropathy. There may be soft tissue changes like ligamentum flavum, hypertrophy, synovial thickening. All these compromise and compression is anterior, so you are doing anterior surgery. Okay? And combined maybe at one stage also. But see, all these teachings are there for the safety of the patient. Okay? You have to have a judgment and you have to decide very nicely in that particular patient what is the issue. Okay? Single stage has been also, but it should be for the little younger patient. Okay? Single stage one can do from posterior and anterior both. Okay? So this is the conclusion. Combined single stage anterior, posterior decompression, reconstruction and instrumentation procedure represents a viable option in the treatment of select group of patients. So you are not going to do this in 90 years old patient. Select, you have to choose how much this comorbidity this patient is already having. Critical analysis of the general condition of the patient and other contributing factors should be considered. Irrespective of the selection of different approaches, optimization of general condition of the patient, control of diabetes mellitus, improvement of the chest function and improvement in the status of the osteoporosis is very, very important. So approach based on number of level involved, 1 or 2 level you do anterior approach. More than 2 level you do combine, later on you can do, but here in this case you will do posterior approach. Okay. So this is also according to this algorithm. If these factors are there, you choose according to these factors. See about the sagittal alignment. Radiological parameter considered during surgery. So you pay attention to cervical lordosis, C2, C7, SBA, how is the T1 slope, K line and occupancy ratio. Okay. So preferred approach, lordosis you do posterior, if patient is having kyphosis do anterior and later on you can do the posterior. Okay. And these are the different methods to calculate. Now this can be asked in your PG exam. Okay. There is a Cox method, there is a Jackson stress line method and there is a Harrison method to calculate the kyphosis or lordosis. So here it is cervical spine, it is lordosis we are calculating. And impact of fusion. Okay, fusion usually leads to adjacent segment degeneration, that is known as ASD in short. Okay, and C2 to C7 SVA. So this line you are seeing, as we see in the pelvic incident, similarly it is there in the cervical spine. It should be 1.5 centimeter. It should not go to the more than 4 centimeter. There is a diagram is there is a toppling of the column in that. Okay, and this is the significance of T1 slope. Normally it is 22 degree. I will be skipping this slide and going directly. So if you have a small T1 slope, you try to have a small lordosis. If you have a large T1 slope, try to create the lordosis. This is important. Okay, 60% and patient is young. You do anterior surgery. When you are going to do the posterior approach, involved level are more than 2. Posterior pathology or long segment anterior pathology, lordotic spine, but there the CSBA is less than 4 centimeter. T1 slope is high, it is more than 22 degree. OPL and reject, K line which is positive, and occupancy ratio is less than 60 degree. Elderly patient with comorbidity. So there is a clear-cut guidelines you should choose in your particular patient. Which one should be chosen? The role of fusion, anterior fusion you do when you have done the anterior decompression and you do the reconstruction and you fuse that area. Posterior multi-segment decompression and alignment. Preoperative axial plane if the patient is having it, you should fuse that area. Correction of the deformity, again you combine this fusion in corrected position. Role of instrumentation, if there is instability or you wish to correct the deformity or you support the anterior structure, we have done suppose the long segment decompression, you should stabilize it, this is important. And OPLL fixation after decompression should be tried. And there is a paper which actually supports all this. I will put this. So anterior surgery you might have assisted ACTF, anterior discectomy or anterior corpectomy and do the fusion. This cervical myelopathy, significant anterior compression you can see here. Okay. So same the alignment, this is the alignment. So this is a classical ACDF and so here the corpectomy has been done and then you just do the plating in that area. Now it is at 2 level there. So here again you can see the decompression and fusion has been done. So here is a stable spine. Just if you do a very good grafting technique, you can see there is a nice fusion in that area. Here at 2 different levels. This at 2 different levels. So discectomy those 2 different levels. You can see almost the fusion is so good, it is looking like a block vertebra. Okay. Now this case of spondylotic myelopathy, compression at C3, 4 and 4, 5, and there is an anterior listhesis of C4 over C5. Okay. So 2 level discectomy, and here this is the H plate we used to have almost 30 years back. So that is the fusion in that area. And here the corpectomy has been done and fusion because it was a case of frank spondylotic myelopathy and we had to decompose the root also. His hand function was very poor. So we went anterior and did this. Localized kyphosis here. So here first you can see that if you do the corpectomy, you are able to create the lordosis and you are having chance to decompress the nerves also nicely. So 2-level corpectomy, distal grafting and plating. And laminectomy, usually as we discussed, what are the cases or indications of the posterior surgery. So younger age, multiple level, more than 2, posterior pathology, ossified ligamentum flavum, and long segment OPLL, you prefer this, okay? But these are the complications which you might encounter, one has to be careful. Then laminoplasty, there you don't take out the lamina totally, you open up this window and try to decompress the cord. This is important. So this may be open door laminoplasty and this is a French door laminoplasty. So there you increase the capacity of the spinal canal. Okay. This is case of cervical myelopathy. You can see the long segment compression. There is signal changes also in the cord. Okay. And you see the element of OPLL. Okay. OPLL. So you can see this is the cross section. Again you are able to see the OPLL. So here both the side we have open and one side you create the hinge and open this whole thing as a single piece. Now you can see visualize the spinal cord. So the space has been created and you tie this on the opposite side on the lateral mass screw. You can see this. Okay. So the space is nicely increased. So now, but in younger patient you try to, this is again OPL. See, it has gone to C1 and this patient was a younger patient. So here I have put with a small mini plate and you can fix this laminoplasty flap. This you can see that small screws and plate there. Okay, and this patient improved. Instrumented fusion posteriorly. You can. This is the lateral mass screw fixation. So this is a nice cord decompression. This patient improved significantly. So these are the advantages of decompression with instrumentation. So there is no post-laminectomic hypothesis. You prevent the instability, progression of OPLL is not going to there, and it reduces the micro trauma to the cord. Okay. So here you can see first stage here we did posterior and then anterior. See the amount of decompression we have done, long segment. Okay. So here again it was a stage. First stage posterior surgery, laminoplasty we have done, and this patient's hand was not improving. The second stage we did corpectomy. So this is the stage procedure. Second was the corpectomy. So this is the final one. Okay, this is the final one. So take home message: in multi-segment spondylotic myelopathy, know the site of compression, extent of compression, consistency of compression, alignment of the column, and any coexisting instability. Anterior compression is most common cause of cervical myelopathy. So you should try to do this anteriorly. Okay, gives a chance of direct decompression. In long segment compression, 3 or more, usually posterior decompression is done with its prerequisite clinical radiological criteria, and instrumented fusion is considered to avoid post-laminectomy kyphosis. Meticulous surgical exposure, decompression and reconstruction facilitates the better environment for neural recovery. I thank you very much for your attention. I know it was very exhaustive.
This is how hardworking those people are. My professor, HOD is also hardworking. We need to learn from them. So going on those lines, I want my PGTs to please come on the first benches. क्योंकि अभी वो surgical video demonstration होगा. So any questions? Any questions in the house?
What is the vertebral basilar artery syndrome you have come across? Because frequently we
Find out the reason for that, you are not able to get it. Because ENT people will say that everything is normal.
Sir, but like 30-40 years age people, they just send it to the orthopedic department.
So actually,
As per
this
my
is a
knowledge-
misconception that patient is having this giddiness or vertigo type thing because of the cervical spine. Unless you prove by MRI angio that in rotation you should ask the history whether he has some problem just few weeks prior. Usually they have URI symptoms, then they have developed this vestibulitis and then there is a vertigo. But what you are telling, the vertebral artery insufficiency, that will happen only when all canals are very tight and rotating the neck will lead to vertigo,
No,
which is not common.
These things are common only after the age of 70-80 years.
Yes, yes.
Not before that.
Not before that.
Yeah.
Not before that. So this is a misconception. Every time they will send to you in orthopedic department or neurology people.
Sir, Anterior compression with the cervical kyphosis, whether you prefer a posterior approach and how will you tackle the anterior compression?
Yeah, actually, this is the thing which I actually try to elaborate. So, what happens if you have the OPLL mass and your K line is negative, it is not going to work by the posterior surgery. You have to go anterior, and you create the lordosis after doing the decompression.
Okay.
So you have decompressed it nicely, you create the lordosis and you fix it in that position. The anterior surgery gives you a good advantage of cord decompression and bilateral nerve root decompression. Bilateral nerve. So the last case which I showed, that person, he had significant myelopathic symptom but a long segment. So what I did laminoplasty. So posterior thing was over. But his gait improved, but his hand function did not improve. So then second stage I went anteriorly and did that anterior orpectomy, root decompression and fused that area. Now in that case I had done laminoplasty. So I have not fixed the lateral mass. So I had that opportunity to create the lordosis in that place.
What is the rate of degeneration once you fix the this anterior segment like C6, C7? What is the rate of degeneration in the adjacent segment after fusion?
See, actually, this varies. Incidences different people include. It is quoted from 2 to 6%, 8%. Okay.
What duration like?
Duration usually it happens. It also depends upon the occupation of the person. A sedentary person will not develop. Okay. A person who is using bike, motorcycle, is on vehicle, multiple times this movement occurs. And then how we have handled during surgery, extremely important. I will tell you. Now we are doing lumbar spine. L4-5 is very common. Suppose you wish to do the flip or T-dip surgery at L4-5. What happens? You are concentrating there, but you are unnecessarily causing damage to the proximal and distal segment. Mainly during exposure, you damage the facet joint. If the capsule is damaged, you have damaged the facet joint. Okay? So the exposure while doing the exposure. So what we operated the case, we took that small incision. We were just concentrating on L3, L4. Okay? We did not touch the facet higher up. We did not touch the facet lower down. At that side also, I did not cut the capsule. I just went to the medial. So the articular processes is there. Now there the inferior will come down, we will cut it. So basically keep that area upper and lower virgin. That is the first thing. Second thing, these patients, the factor of this ASD is not just occupation or something like that. First thing, how we have tackled the previous surgery, how the previous surgeon has tackled that thing. Second thing, it starts with the
young people with the disc herniation at the cervical level.
So all these discs they fuse. Don't do it. See, we used to always tell, be 10 years behind US. Let them practice, see the outcomes, and then you follow. So you don't spend money. See, I am not at all convinced. In spinal column, apart from mobility, stability is also important. Actually, in US, I actually attended the course for this disc replacement. Okay, the lumbar spine disc replacement has already failed.
Already failed. Yeah.
Already failed. All of you agree?
Yeah.
Cervical spine also. Again, how you see? I have given a talk. It was a debate. There is only one indication for disc replacement. There are 13 contraindications. Okay? So when you do this disc replacement, this cervical, young patient without involvement of the facet, posterior element is absolutely virgin and normal. You have disc prolapse, patient might be given myelopathy. There you can do this procedure. It is made for that only. So if people they do extended indication just for industry driven, 2-level, 3-level disc replacement they will do. It is not required. Nowadays another thing which has come in the picture. See, the US people, they started doing in 2008. So if you have converted the disc with the ACDF, now the ACDF adjacent segment degeneration, so now proximally you have the degeneration. So they started now putting disc replacement proximally. So there is a combination. Lower down there is the ACDF and higher up is the this replacement. So disc replacement again, single level and you are doing, and you have done a lot of bone dust, you have rubbed the thing with the burr and all, no? It goes into a kyphosis. So disc replacement is there, but there is no advantage. And even in long, if you see the series there, that movement is maintained just for 1 or 2 years. It gets auto-stabilized.
So in cervical myelopathy, after surgery, they are going to recover fully, or he just doing to prevent it further deterioration? What is the
Both the things are there. They do recover. Okay. So as we discussed yesterday also, we are not totally concentrating on cord. We are also concentrating on nerve root. The hand function is extremely important. One power increase in the power in the hand, it makes a lot of difference in the rehabilitation. Okay. So they do recover. Non-ambulatory patient becomes ambulatory. I have treated a patient who was a taxi driver. He was bedridden for 8 months. Okay, and now is a bread earner. So we should not leave it.
time duration?
Time duration, these are the criteria which I told. If this deficit is more than 6 months, the compression ratio is less than 0.4, and the Pavlov ratio, or that we just now discussed about your cervical spine X-ray, that is less than 0.8, the prognosis is poor. The compression ratio, torque ratio, and the duration, these things are important findings.
Thank you, sir.
Thank you very much.
Actually, the discussion which was going on, that is very important discussion, but particularly for the spinal surgeons who are doing this surgery.
Yes.
But on now, I like to ask 1 or 2 questions on some of the PGTs.
Yes.
That is, in case of, number 1, in case of cervical or even lumbar, lumbosacral myelopathy, with the root symptom also, when you will conduct the operation, that means the initiation of the operation, how you decide that this patient will be immediately operated, or after some maneuver you are going to operate.
Only indication is cardiac one. After that, progress in everything.
Yeah, this is a very vital question. I think sir has definitely asked us to address this to all of you. You should understand. Once you learn spine surgery, you want to operate each and every case, which is disaster. Okay. So if a patient has come with the first time disc prolapse without any neurological deficit, you are just seeing in MRI, don't operate, because that patient can be treated conservatively. Now also, I put patient on traction. So traction is not obsolete. Collar is not, you should know how to give them. So nowadays nobody wants to spend time on these things, and that's why you are just for the surgery, which is actually bad thing to happen in our society. Okay. So if the patient is having lumbar disc prolapse, L4-5 is the commonest site which is involved. First episode, there is a radiological changes also. Patient has radicular symptoms. He is not having any neurological time. First thing is conservative. Literature and textbook says 95% patients become alright. You should have patience, and patients should have also patience. They become alright. Okay. So suppose again he comes back to you. Okay. After 2 years again comes over. Why he comes repeatedly? Because you have not built up his muscles. So once he recovers, he improves. Don't start exercising from the first day. It's very painful. He has spasm. He will never do that. So once his thing has become cautioned, he is now okay, then you start exercise. Okay? Exercise protocol are there that you should do, and strengthen him and tell that if you don't do this, again you are going to come back. Okay? So he should take care of that. Apart from this medical and surgical thing, there are other things also. All these patients, their bone is sometimes porotic. They say they have small snode. They are the signs of actually early degeneration in these patients. Okay, they are osteoporosis. Treat those patients. You should not treat back pain. You should treat the radicular pain, I am talking about the disc thing which we are discussing. So for back pain, you don't operate, okay? Because there are many causes of back pain. So you should first identify the cause. What is the cause of back pain in that particular patient? And there are diagnostic blocks nowadays we are using. So if suppose patient had radicular symptom, here you are finding 2 level disc protrusion. There you give a block and see whether he has got relief or not. So initially try to treat conservatively in this patient. If patient has developed neurological deficit, if he has developed now clear cut on the right side, the power is L4 of EHM, on the left side is L5. For L5, L4, you know, that root, the grade 4 power is not an indication for surgery. Again, you put the patient on the anti-inflammatory drug, rest, that I use usually retraction, and the patient come back to normal. Okay? The case which sir actually just raised, that caudal corner syndrome, that patient has the corner, it is an emergency. You should do as early as possible. Okay? So there is involvement of bladder wall also. That takes a lot of time to recover that. Okay? So that is emergency in spinal surgery. The patient has come with the caudal corner syndrome. You should operate as early as possible. Otherwise, just radicular symptoms, no neurology, there is no need of any surgery, because these patients can be treated very nicely. Even if suppose patient has significant radicular pain, his power is normal, he has just radicular pain, just radicular pain, no back pain also. You think block, nerve block, he is fine. Okay, so try to defer the surgery as much as possible. Okay, now this case which we operated today, that young, he is 30 years old male. He is having disc protrusion at 3 level, but the symptomatic disc is the large one which is at L3, L4, which we operated. So that is, so if you plan in this case 3 level discectomy, fixation and fusion, you have actually fired his 3 level motion segment in that young patient. He will come again after 2 to 3 years, adjacent segment at proximally and 1 level which is like your L5 is. Okay, so limit your fixation. If patient has instability, then you cannot afford living like that. You have to fix. If there is a fine instability, and that is the reason we got flexion extension diugram. That is known as dynamic extension. Okay?
Sir, one
Actually, in addition to that, there are a lot of articles also, there are evidence-based articles, where it has been observed that even with a disc collapse, acute disc collapse, with radiculopathic vein, and the muscle power is little low, L4, something EHF power. In that case, the serial follow-up, non-operative treatment, serial follow-up, and serial MRI has shown that the disc has been completely resolved, completely disappeared. The protruded disc has been completely disappeared. This is evidence-based literature showing. And in the clinical practice also we are following this. And in the way how I do separate the patient, one is a group of patients with acute pain, acute back pain, without any radiation. That is one group where the simple non-operative treatment with your available regarding the tax, and there are certain controversy, but you can get operation subsequently. And the third group is where the pain is due to certain disease. It is because of that may be tuberculosis, that may be some other tumor condition or some other diseases. In that case, it is okay. So in that case, we have to go for all sorts of investigations, and even the histopathology can be obtained to certain your diagnosis and treat the condition as it is demanding. So this is the way what I think, and I want to convey it to you. And my one of the last question is for all of us. That is, what is the jurisdiction in case of is the spinal cord is incorporated in the spinal column. And what is the jurisdiction of the spinal surgeon and the neurosurgeon? That is number one. Yes, that is number one. And the second one is who is qualified as your spinal surgeon? That is a two question which is a long duration debate, and probably the apex court also consider it. So we should have the clear concept on that. Otherwise, legal issues can attack us. So let us see from Srivastava.
Yeah, actually, this also we have discussed in our national
Yes,
conference.
yes,
Okay? An orthopedic surgeon has every right to operate on the spine. Why? And this is the statement of that medical legal person. Whether the spine chapter is there in your MS course or not. Yes or no?
Yes.
Yes. Whether you get a case of spinal pathology in your MS exam or not. Yes. So you have been taught thoroughly and you have every right to operate on the spine problem. Every right.
So we have a training for
Yes.
fellowship programs. So
Yeah.
definitely-
No, so this, it is beyond. It has been, and this statement was a medical legal person standing on that podium, telling you have every right, if you have any case, you bring it to me. And Association of Spine Surgeons of India, we have addressed this issue to the higher apex authority. Okay? And one case which had happened in South, and we produced that paper, and he came out of that problem. So all orthopedic surgeons can do spine surgery. Only one thing, sir, I will just finish that. If you have a intramedullary tumor, there you will take help of neurosurgeon. Okay? There will take up neurosurgeon because of the other advantages also. They usually use microscope. They have all those gamut of instruments to deal with the intramedullary. Otherwise, spinal column pathology giving rise to spinal cord, it is in your vicinity, and you have full right to tackle those.
Sorry, thoracic disc.
Yeah.
I have a case. Actually, it's so difficult to operate thoracic disc because most of the time they are so hard.
So
in that situation, I went through the posterior approach, but I could not completely remove it because it was so hard. So usually, how do you do
yeah,
the
I have done many of that, and just after this talk, I will give you my published paper on that. So the way of doing in
Because
I think I am loud enough. So patient is lying prone, you have exposed, and as he has just now mentioned, you go posterior lateral. So your trajectory should be like done or not, that the CT will guide, and MRI will guide. Suppose you have one side, so there you go, then you create a space between these two vertebral body. You make a kaddha there. Getting my point? Then you burr out, make it thin, and push the whole thing anterior. Okay? So we have done many cases, and I have published it also. Maybe photograph is also given to that. So you go from one side, take out the pedicle of that side, and then go more deeper, create a hollow there, and the disc which is lying there just jutting into the cord, you make it thin, and then all these are calcified or ossified, whatever it is. Make it very thin, and then you make a space laterally here, and then push that small fragment anterior.
Thanks.
Good. Neurosurgeon, they have tried through the thorax, and if you happen to pierce the dura, you have a hell of a problem. The whole thoracic cavity is full of CSF. So if you wish to do anteriorly, first prerequisite, put a lumbar subarachnoid drain. Otherwise, this will not stop. You have a hell of a problem. It is like as you puncture the thoracic duct,
Yes.
and the whole bag is full of milk. The same thing is CSF. So people, they have gone again to seal that because it keeps on filling the thorax. Okay, and then patient has shift of the mediastinum and all this problem. So if at all you wish to do it anteriorly, put a drain, lumbar drain, okay, for CSF bypass. And then you do this. In case you happen to puncture the dura, this will take. Otherwise, it can be very nicely done from the sides.
Yeah, that's what. The
Yeah, posterolateral. One side. If it's suppose is the dead in the center, you go from both the side and fix that leg. So it is stable also.
Sir, we
I have a published paper.
I have to
Actually,
think.
for 3 years, I was member of the Indian Orthopaedics Association Executive Committee. And at that time, regarding the spinal surgery, spinal surgeon, neurosurgeon, the controversy was
It was there.
It
Now
was
also
there.
there.
Now it is there, but at that time, what was decided, that is, when something arises out of the spinal column, that the ligamentous structures, that very well can be dealt with the spinal surgeon, but when the pathology is arising from the cord itself, then that is the jurisdiction of the spinal surgeon. Even jurisdiction.
Yes, 5.9 per kg body weight at 24 hours. So that was the NAS criteria for that. Right? But personally, I have found a complication. These patients, they are prone to develop pulmonary edema. So you have to be careful. Don't do it without the care of the ICU. This is important. Okay. So they have tendency to develop pulmonary edema, and this is very, very important. Usually, I don't give this loading dose of steroid. That's why this is actually a cooked literature. It had gone into the court in America. Okay? So few people, and that's why it went into controversy, that people are actually benefited by this company, and this is company sponsored trial. Okay? But in exam you are asked, you have to tell this dose. It should be given when the patient comes. This is the latest criteria for that. Comes within 3 hours. Earlier it was within 8 hours. So that was the period. Many a times you will not find places in our Indian community that they didn't do patients so early. Okay? Otherwise, this is the recommended dose. And at the most, what you can do,
5 milligram. The loading dose.
30 loading dose is 30.
Very famous.
So is it going to be toxic for you?
नहीं ये अभी आपको अच्छा लगेगा क्योंकि इसमें ये सर्जरी दिखेगा.
First put the lateral mass.
अच्छा
And I have covered everything of dorsal spine. Okay? Second, dorsal spine teeth. Affection maximum in the dorsal spine. And commonest is the paradiscal. So we divide into 4: paradiscal, central, anterior, and posterior tuberculosis. But there may be circumferential involvement. We, for our study's sake, we read this, but bacteria doesn't follow any classification. Okay? So all the column may be involved, and you can have a circumferential involvement. So what are the indications of surgical intervention when patient has neural compression and deficit, when there is a instability, when there is a progressive deformity, and there is a significant loss of supporting column. Okay? This is important. The principle of surgery in TB spine is neural decompression, internal fixation for stabilization and deformity correction, and reconstruction of the column and fusion. A surgical approach should facilitate the performance of these surgical steps. Now, so this is the axial view of the vertebra. You can go from behind, you can go posterior, there is a midline, you can do laminectomy. Laminectomy is only done when there is a epidural mass or epidural abscess, because usually the posterior element is normal in TB. Okay, you go anteriorly transverse. Okay, you go between the ribs, you go in the chest. You can do anterior and posterior to the two separate incision, or sometimes you do with the single incision. And this ALD, that is the anterolateral decompression. This was very common in the past. People used to do all cases ALD. They used to do. So now this patient has neurological deficit. You can see the significant posterior compression in this patient. Okay? So here laminectomy has been done, posterior midline incision, and you remove this whole epidural cup, and now you can see the cord is absolutely nicely visible and decompressed nicely. and this is the X-ray after surgery. The laminectomy defect is visible. Okay. Now this was in young girl. So in young girl, if you do such amount of laminectomy, they have the problem of developing kyphosis later on. Okay, more so. So here the laminoplasty has been done. I have tied. You can see that wire. Okay, I have reattached it. Okay, so this was a girl, young girl. Now you can do posterior decompression. You can take midline incision, laminectomy, removal of the organized epithelial in that area. Okay, because if you see, even we say artery of Adamkowicz, that is D9. Okay, so this area is actually vascularity wise, this is the common involvement. Okay, what is the primary tuberculosis? It is in the lungs, so it goes there. And lumbar spine, it is happening because of the Batson plexus. Okay, so with the lesion you have, so if patient is having arterial inoculation of vertebra, it is the paradiscal lesion. It is according to the embryology of the vertebra. You might have read it. Okay, so this one branch, it goes to the lower part, and another is going to upper part of the distal vertebra. Okay, so because if the embryology, this supply is there, so that's why the paradiscal lesion, the inoculation is by the hematogenous route in arterial tract. The Batson plexus, so patient is having, genitourinary tuberculosis, they have tendency for inoculation to the venous plexus because Batson plexus is a valveless vein. Okay, so then you get a central type. Okay? So these things are
And DK Parcel, we will come here on the stage for a photograph.
Dexamethasone as a lower dose. I usually give 8 milligrams 6 hourly. Okay, for other cases also, the patient with the neurological deficit in the spine because of the disc protrusion and he has deficit, I usually give in the tapering dose and he withdraw that. You give, it is a strong anti-inflammatory drug and it is a neuroprotector also, so it helps in that way. Okay. Otherwise, personally, I don't use this loading dose of steroid because I had one patient who had developed pulmonary edema.
Sir, also another question. As you are a proponent of conservative therapy, we want to know what should be the indication to use traction, basically for lumbar disc. What is the time period or the day period? Because nobody is going to be ready to lie down in a bed and for 21 days at this given age and time. And what are the indications and what are the contraindications?
Yeah. So a patient who is having instability, okay, and he is having this prolapse and there is a neurological deficit, you should not conserve this patient because they are bound to fail. This is so. Now, giving traction also, one should learn how to give traction. Many times we put the patient on traction and it becomes, the patient will come, mujhe to bahut zyada pain hone laga. Okay, and he will throw it. So you should maintain the vector. How this thread is going to the pulley is extremely important. Okay, the spine, you should see pre-traction, what is the alignment of his spine. Okay, so try to keep in little flexed position. Cervical spine, keep it in neutral or little flexed. If you give traction in extension, patient will have. That's how the bad name has gone to cervical collar. If you have not seen the collar which the patient is wearing, and if the collar size is more, it will put the cervical spine into extension and patient will deteriorate. His symptom wise, he will say, "Mera dard badh gaya aapke collar dene se." So problem is not with the collar, problem is with our understanding. My female ward in KM hospital used to be always full with this problem. Why I used to admit the patient, I will tell you. These are ladies. Our Indian lady, they will not take rest at home. वो कभी नहीं देखना चाहेगी कि उसका husband कुछ काम कर रहा है, उसका बेटा काम कर रहा है. She will definitely get up and start working. Okay? And what is the amount of work we are doing at home? Maximum on the floor level activity. Okay? So they don't get time to do all these things, follow your command, and you will give bad name to that conservative treatment. So I used to admit these patients. So they used to get free food, there is a toilet, and she is under my observation. I am going to take a round and see whether her EHL is improving or not. I used to insist on the family member, no, I want this lady to be here only. And they used to cooperate. Okay, and you see the fantastic result. The disc surgery, acute disc prolapse in my unit was 3 or 4 in a year. Okay, and I actually stand in any conference and I will tell, I still use cervical traction and I am one of the examples. I had grade 3 bicep, I had cervical disc prolapse, I used to do long out thoracic surgery. And I had that, I put myself on traction, I took dexamethasone, I recovered fully. So it does work. All these old techniques in our orthopedics are very, very useful. This technique is disappearing, it is